Hello, friends and colleagues. Welcome to a webinar that has been produced by one of the subcommittees of Vision Serve Alliance's Aging and Vision Loss National Coalition. We started this coalition about 3 years ago in order to assure that issues facing people over the age of 60 years old living with low vision or blindness were addressed on a national level. We are appalled as a group at the dearth of quality services available and even more so by the lack of funding and financial support that these constituents, far and away the largest population group of our constituents, by the way, are given through our national systems and state systems and local systems. And so we have been dealing with a number of important issues: policy and funding, public awareness, data and research, and certainly not the least of these is access to quality services. If you're involved in this field, you know that there are very few certified vision rehabilitation professionals and way more people who need services than there are professionals available. So, one possible solution is including qualified occupational therapists and OTAs on your multidisciplinary teams. So, this webinar today will offer some interesting insight and discussion and additional food for thought that we no doubt will continue to talk about for many months to come. And with that, I'm going to turn it over to our host with the most, Anicio Correa.
Well, thank you, Lee, so much for that introduction. And we should be on slide number 2 with the purpose of this webinar. And in this, and then we'll go to slide number 3. We're fortunate today to have a number of panelists who are experts in occupational therapy and low vision and administration. And each of them will be talking about specific issues associated with the role of occupational therapy in the provision of vision rehabilitation services. So we'll start by focusing on what occupational therapy is, what it is not. We'll talk about scope of services, credentialing, all those good things related to occupational therapy. We'll then go on to talk about issues associated with the billing and documentation requirements from a medical model introduces to the services. We'll then highlight 2 specific programs where they have been able to introduce the medical model into the more traditional vision rehabilitation services, and they have been able to make it work. That's the case of the Center for the Visually Impaired in Atlanta and New View, Oklahoma, in Oklahoma. We will then go on and talk more specifically about some of the challenges that can arise when integrating this medical model into the more traditional social service or educational model. And the panelists will then propose and outline some strategies to overcome those challenges. We will conclude by talking about some next steps, some exciting things going on in terms of continuing education for occupational therapy, some additional certification opportunities, etc. It is important to note that the services that we describe here are just examples of what some organizations have implemented. There are many different ways of doing it, and we certainly don't want it to come across as this being the only model. I also don't want people to get the impression this is a primer on how to implement an occupational therapy or into the low vision provision of services. It's not. It's just a just the beginning, as Lee said, of the conversation. And hopefully there'll be lots more conversation and lots more opportunities to discuss the topic. In terms of questions, we welcome questions in the chat box. Ellie Dupre, one of the co-chairs of the Access to Quality Services Committee, has graciously volunteered to get those messages, transcribe them, put them together into some meaningful form if there are more than one set, more of the same questions. And then she will ask those questions of the panelists at the end. So thank you, Ali, for doing that. So don't wait until the end. Feel free to write down those questions as they come up. And without further ado, it's my pleasure to introduce the first speaker. And then from then on, each speaker will introduce the next. But the first one is Dr. Beth Barstow from the University of Alabama at Birmingham. Beth, the microphone is yours.
Thank you, Anicio. I'm just one speaker for this portion, and just to tell you a little bit about myself, I'm an OT. I have been for over 30 years. I'm an associate professor at UAB, and I also direct our graduate certificate in low vision rehabilitation that we offer to practicing clinicians throughout the world. I go by the pronouns she, her. I'm a Caucasian female. I have long, straight, dark hair, and I'm wearing a black shirt today. My co-presenter today is Nalima Tana, and I'm going to let her introduce herself.
Hi, everyone. Thanks, Beth. My name is Nalima. I'm an occupational therapist by background. I have my specialty certification in low vision from the American Occupational Therapy Association and my CLVT from ACVREP. I've been working in the field of vision rehabilitation for the past about 20 plus years. I've worked in multiple settings and multiple roles as a clinician and helping develop programs to add OT services in ophthalmology clinics, low vision optometry clinics, and nonprofit. I also serve on the board of ACVREP. I'm a short Indian gal with dark hair, and that's me. And we can get going, Beth.
All right, next slide. All right, so we thought we'd start off today by just talking about what occupational therapy is. Both Nalima and I have years of experience in this profession, and I think she will agree with me that weekly, if not daily, we get asked what OT is. And it is a misunderstood profession that often gets compared to physical therapy. We get asked all the time if we're going to find people jobs. And the answer to both of those questions is, yeah, maybe, and yes, a little bit. The definition of OT by the World Federation of OT is that we enhance a person's ability to engage in occupations. And we define occupations as activities of daily living. So we, first of all, enhance a person's ability, but we also, when a person needs to or is expected to do it or they want to do it, we also recognize that environments need to be modified as well as tasks for a person to be able to engage in occupations. And so I like that definition because it tells you a lot about OT. First of all, we work on improving the person's skills, but we also recognize that disability is sometimes predicted by the environment and task that someone is going through. So we also look to change that. And we as OTs matching the person to the environment and task call that the just right challenge. We are a client-centered health profession, and our primary goal is to increase health and well-being of individuals through occupation or activities of daily living. Through planning of this conference, we've talked a lot about OT and activities of daily living, and I was surprised to hear that some OTs are actually wanting to be supervised in activities of daily living for people with vision impairment, and that just, it shocks me because that's really our bread and butter. OT started off in World War I, and we were called reconstruction aides. So when soldiers were coming back, they had, issues with physical disability, sensory disability, and grief and loss issues with mental illness. And so OT started out as reconstruction aides implementing crafts, arts and crafts, as a means to rehabilitate, but also as the occupation itself. Now, we have progressed like most professions do. And in World War II is really when we changed to being focused on activities of daily living. And so OTs will work with individuals, with populations, and with groups to work on improving activities of daily living across the lifespan. So we work with children in neonatal intensive care units all the way to older adults. And OTs are used to working outside of the medical model. We have OTs that work in nonprofits, in prisons, in outpatient clinics, in homeless shelters. So OTs are very versed in working in different types of practice settings. We are registered and licensed healthcare providers. So upon our didactic education, we sit for an exam, and hopefully we pass it. We have to become licensed in our state of practice, and currently all 50 states have some sort of licensure that mandates OT practice. There are two types of OT practitioners. We have the occupational therapist, and we have occupational therapy assistants. Occupational therapy assistants graduate from a 2-year university or college, and they are skilled in addressing interventions. So they have to be regularly supervised by the occupational therapist. They can't complete evaluations, can't modify plans of care, and can't document discharge. And so they work hand in hand with the OT. OTs, on the other hand, can have a variety of degrees. You will see OTs with bachelor's, master's, and doctoral degrees, just to make it more confusing what an OT is. Right now, schools and our accreditation board mandates that all programs be at the master's and the doctoral level. And when I say doctoral level, I mean an OTD, an OT clinical doctorate. And so these therapists graduating aren't getting research PhDs, but they're getting degrees that allow them to move into clinical specialties and management roles. The bachelor's degree still comes into play because that was phased out about 15 years ago, but there are OTs that still have bachelor's degree that were, of course, grandfathered into the profession as being able to continue practice. Next slide. So what does our schooling look like? It's different. Like I said, the assistants are 2 years, the masters are typically about 2.5 years, and then the OTDs are about 3 years. But it starts with a foundation of sciences. So neuroscience, biomechanics, anatomy, and moves quickly to conditions. And the OT that goes into an entry-level program will get schooling on psychiatric conditions, physical impairment, sensory, developmental, et cetera, et cetera. So our education is very broad-based. We don't leave schooling usually being a specialist in any area. OTs are experts, again, in activities of daily living. And with that, we learn to do activity analysis. So not just breaking down an activity and understanding, is that a sensory component or a physical component that the person needs, but even breaking it down further, like what joint movement needs to be made, what eye movement needs to be made. And so we get lots of schooling in that, and then tying that with how does any given condition cause limitations in that activity and ultimately occupations. We learn how to assess and intervene, again, for individual groups and populations. And our focus is on prevention, but also rehabilitation. And we want to promote the health and wellness to preserve someone's occupational identity. So when an illness or injury occurs, a person loses those valuable activities of daily living that define who they are. And we work very hard in OT to give that back to them, working side by side with the client to develop treatment plans and goals. Again, our settings are varied: hospitals, nonprofits, community-based rehab, private practice, you'll find OTs in almost every area of medical and non-medical treatment. Next slide. Nalima in the next slide is going to talk a little bit about the OT practice framework. I like to think of the OT practice framework kind of like the Bible of OT. It tells us what we should do in our profession and tells us the areas we should address. So when we take a client, our process is to first evaluate them. We develop an occupational profile, what they can and can't do because of their injury or illness. And then we complete evaluations that align with their needs, develop a plan of care or an intervention plan, and then carry that out and document outcomes. Now, through that process, the domains that we hit are on the left-hand side of the slide here. So we always address occupations or activities of daily living, and that can be anything from driving to cooking to eating to dressing. We look at the context of what either facilitates or inhibits a person's ability to complete occupations. That can be anything from the support system to the environment that they live or the environment that they work in. We look at performance patterns. So what are the habits, the roles, and routines that this person has followed during their lifetime? We look at performance skills. And so for any given activity, let's say, for instance, cooking, what skills does that person need to be able to resume cooking if that, in fact, is a valuable activity for them? And then we also look at client factors. So what skills does the client bring to the table with them that we can improve or capitalize on to work on increasing safety and independence? Next slide.
All right. So irrespective of whether occupational therapists are billing for their services or not, because we are licensed healthcare professionals, we need to follow certain rules and regulations. AOT standards of practice for OT are requirements and minimal standards for the practice and delivery of OT services. The OT is knowledgeable and provides services in accordance with the AOT standards, policies, and guidelines, state, federal, other regulatory and payer requirements relevant to the practice and service delivery. So all OTs abide by the code of ethics and also all the official documents that clarify and support OT practice, like the OT framework and scope of practice. We also have other documents like documentation guidelines, supervision guidelines that we follow. And like Beth mentioned, the OT framework really is our Bible. It kind of guides us in our work. And the scope of practice that we bring to the table when we are hired as occupational therapists in the vision rehabilitation world is pretty broad compared to the scope of practice that we might bring as a CLVT. And so it's essential to recognize the OT scope of practice and the framework that we come with. Beth?
All right, next slide. All right, so how many OTs are there? And this, presentation was put together a week ago, and it's probably dated already, but currently there's 174 entry-level accredited schools in the United States, and that's both assistance and therapist programs. And our schools are accredited by our accrediting body called ACODE, but above them is the United States Department of Education. And so they mandate really what needs to happen in an OT program to become accredited. We have, 200 to 300 different standards that every program has to follow, and it will get accreditation if in compliance for 7 to 10 years. There's an estimated 141,405 occupational therapists throughout the United States, and this is probably the stat that is already dated. Most OT programs admit a class of 30 to 60 people, and so they're graduating them at different times during the year. But the idea is that OTs are widely disseminated in both rural and urban areas and can be well suited to work in specialty areas of practice. Next slide. So how are OTs trained specifically to work with individuals with vision loss? This is a few ways. It certainly isn't an exhaustive list, but one of the primary ways is through graduate certificate programs like UAB. Salus University on the East Coast also has a program for OTs to become certified. Duke University, which isn't on this list, is currently developing a program that will interface with the CLVT. And Western Michigan had a program, but is currently not admitting therapists. But these graduate certificate programs are designed for people who have already graduated with their OT degree and wish to specialize in working with individuals with vision impairment. Other ways that OTs can prepare is by doing a field work. So upon completion of our didactic coursework, we have to do 2 3-month clinicals in a setting or an environment that we and our field work coordinator choose. And we work, by the end of that, we're functioning fully as a therapist. Now, the OTD has an extra semester tied onto that to do a capstone where they may focus on something like vision impairment. There are some OTs that do a field work, a level 2 field work, which is what we call it at the end, in low vision or vision rehabilitation, and are ready to hit the ground running after that. There's also mentoring, and the CLVT is a perfect example of that. That requires some mentoring to get that certification, and that's another way that OTs can become skilled in this area. And then concentrated continuing education. It is my pet peeve when OTs go to a weekend seminar and then feel that they're skilled enough to work in this area of practice, because we all know that is not the case. So when we say concentrated continuing education, this is self-study continuing education. It may be paired with a weekend course, but it's a sustainable continuing education. And you may pair continuing education with fieldwork, with mentoring, with graduate certificates. Usually one of these doesn't happen in isolation, but it is a mixture of a couple of them. Next slide. So in the field of occupational therapy, we have many specialty areas, and working with individuals with vision loss is just one specialty area. Other examples may be an OT who works in hand therapy, or an OT works in lymphedema. There's lots of examples. And to separate those OTs from the ones who don't work in specialty areas, we use the terminology generalist. And so a generalist OT is someone who has graduated from accredited school, who is registered, who is licensed in their area of practice, and works in any practice setting. So it could be inpatient rehabilitation, it could be outpatient therapy, it could be pediatric setting, but they have a basic knowledge of vision impairment. And I will admit, this is going to depend on the school that they graduated from with their entry-level degree. And I'll give you an example. At UAB, we have a whole semester that prepares our students to be generalists in the field of OT and be able to identify vision loss in individuals, where other schools might only have 1 to 2 courses. So you have to be aware of the program that they graduated from. But generalists should all know how to adapt tasks and environments to meet their current treatment goals. So they're never going to write goals based on vision impairment. They'll write goals related to their current injury or illness. So for example, it could be somebody who is working with someone with a spinal cord injury who uses a wheelchair, who's in a kitchen, but also has a comorbidity of age-related macular degeneration. Because the OT has a broad base, they know how to do simple adaptations so they can meet their therapy goals for their particular setting. These individuals also have knowledge of referral sources, so they know who to refer to if they think a specialist needs to see the person. Is it an optometrist? Is it an ophthalmologist? Is it an O&M? Is it a specialist in OT? whatever have you, they know how to refer. And if you get a generalist who graduated from a school who has more in-depth training for their generalists, they're going to be able to screen for vision impairment. They're going to be able to do basic acuity and contrast screening that would alert them that I need to refer to a specialist for further training. It doesn't diagnose, it doesn't do anything other than trigger a referral. Next slide. So compare that to the specialist in low vision rehabilitation or vision rehabilitation. These are still therapists who have graduated from an accredited program. They're registered and licensed, but they have additional training above and beyond their entry-level degree that will allow them to work with individuals with vision impairment. And we just talked about ways they can obtain that. They treat and assess for how vision impairment impacts occupational performance or activities of daily living specifically. This includes the application of assistive technology, task modification, environmental modification, whatever is needed to meet the goals. They also have training in diabetes self-management, so they can work side by side with a certified diabetic educator. There are some OTs that are certified diabetic educators and work more thoroughly in that area of vision rehabilitation practice. They work on bioptic driving. Some work behind the wheel, but most do it in clinic to prepare them for the behind the wheel. Neurological vision loss. So if you think back to our entry-level education, we have neuroanatomy, we have anatomy, we know how to address issues of neurological vision loss like ocular motor deficits or hemianopsia. We can treat across the lifespan. We're able to address the secondary health conditions because of that broad-based education. These OTs that are specialists may or may not have certification. It is not required to work in the field, but it is considered best practice for OTs to have some type of certification to work. And many do possess graduate certificates because that has been our main area where we can achieve competence in education. Next slide.
So now I want to address some misconceptions regarding occupational therapists. And when I talk about occupational therapists here, I'm talking about specialist occupational therapists. The first misconception is that OTs are not skilled at working with strategies of non-visual strategies with individuals with vision loss. Non-visual strategies are one of the many strategies routinely used by OTs when working with the client so that they can achieve their goals. As specialist OTs, sometimes we get stumped and hit an activity where we have to do the activity analysis, use our unique skill set, research and seek resources so that we can meet our patients' goals. The second misconception is that OTs are not skilled in working with the older blind population. And as Beth mentioned, OTs work with individuals across their lifespan. And I think the term blind or blindness is often used differently in the medical community and agencies or organizations. So in the medical community, when we talk about blindness, we're talking about an individual that has light perception or no light perception. Agencies and organizations often use the term blindness and legal blindness interchangeably. And I think that causes, between the medical community and other organizations, some confusions. Specialist OTs are skilled at working with individuals across the wide spectrum of vision loss. I would not say the same about the generalist, but it's kind of like going to a general ophthalmologist when you're recently diagnosed with RP or macular degeneration and expecting the same level of care as you would with your retina doctor. So I think understanding that vision rehabilitation is a specialty area for occupational therapists and expectations from specialist OTs and generalist OTs need to match their unique skill set. Next slide, please. So I think OTs are perfectly matched to work with the older blind population. We're trained in disability and aging. we're able to address their physical, psychological, cognitive, and social needs. The focus is positive. We want to optimize a person's daily functioning. And as OTs, we love to collaborate with other care providers. And as you all know, we are reimbursed by Medicare and other insurances. Next slide, please. Before we go into what to look for an OT, I want to take a step back. Oftentimes, OTs are hired by agencies because we're connected with the medical community. Also because we can bill for our services. And I'm sincerely hoping that after our webinar today, people think about hiring OTs for the unique skill set that we bring to the table. To the leaders, it is important to recognize that unfortunately, even today, OTs are either perceived as a threat or as non-skilled professionals in the BVI community. So, number one, there has to be a buy-in, not only by leadership, but also, or board, but also by mid-management and staff level. There needs to be a plan as to how OTs will be integrated into the current programming before the OT is hired. There has to be clear communication in a positive manner regarding the reasoning behind adding OT services. This will make the transition much easier for everyone. The supervisor for the occupational therapist needs to have a really good understanding about the scope of practice and the overlap in services. Communicating the same with the current staff will be critical when, integrating OT services. I believe Beth has done a great job in explaining the differences between the specialist and the generalist OT. So if you already have a generalist OT on staff, I think getting them mentoring by a specialist OT, investing in having them get the additional education through a university program or through sustained continuing education would be a great way to increase their knowledge base. Next slide, please. So how do I find an OT? There are a couple of certification lists. ACVREP has started creating a list of occupational therapists that have their CLVT, which is the certification low vision therapist. And it's not on their website right now, but I volunteer Kathy Sider. If you reach out to her, I'm sure she'll be able to find you some in your state. The other certification that a lot of the occupational therapists have is a specialty certification in low vision from the American Occupational Therapy Association. Contacting a university with a graduate certificate program like UAB, Salis, Western Michigan, and in the future, Duke would be a good resource. Contacting state OT associations or an established OT who's currently working in low vision would be a great way to find an OT because we do network a lot within ourselves. Next slide, please.
All right. So Nalima talked about where to find an OT. So you hire an OT, what can you do to retain them? Nalima hit a little bit about on this, but it is imperative that you understand the depth of training and the profession that OT is. If you're, requiring them to do things within their scope of practice, and you're requiring them to need supervision, there isn't any better way to get that OT to leave your organization because they're not going to feel respected. And that would be for the trained OT in low vision or vision rehabilitation. If you're looking for resources about OT, the American OT Association is a great place to look. They have a pretty comprehensive website, as does the World Federation of OT. Another thing is to adequately and fairly compensate them according to what the market value is in your area. It's different across the United States because our states differ per cost of living. But remembering that they're registered and licensed and they're able to bill through insurance and Medicare, so they should be able to recoup quite a bit, if not all, of their salary in a given year through the clients that are being billed for services. Nalima mentioned collaboration, and I have this on this slide as well, because OTs are used to working in interdisciplinary settings, and that's how we thrive. We're not individuals who go into this profession because they want to work on an island. They very much want to collaborate and respect other professions and feel as though a team approach is better than just going out on their own and solving a problem. And then the last part is the CLVT, the Certified Low Vision Therapist. Somebody had asked about that acronym before. Thank you for those who typed it into the text box. Is understand if an OT has that certification, they're much more than a CLVT. They're not going to just work on reading, writing, magnifiers, and assistive technology. But remember that ADLs, activities of daily living, are our bread and butter. And so that OT should be able to work outside of the CLVT roles and responsibilities. We're also different from other rehabilitation vision professionals. We're different from O&M. We're different from, the certified rehab teachers. So, hopefully we've given you a little bit into insight into how we differ and the skill set that we can bring to the table. Next slide.
Jackie, you want to take this?
Sure, I can kick this off. So my name is Jackie Borchard. I am by background a speech language pathologist, but with over 10 years of experience in rehabilitation management. I currently work as the Director of Operations at Vision Forward Association in Milwaukee, Wisconsin.
And I already introduced myself. This is Nalima. I'll be presenting with Jackie. All right. So before going into the OTs practicing in the field of vision rehabilitation, we thought it would be good to understand how OTs work in the clinical setting outside of the world of vision rehabilitation, so that the expectations are understood. Normally, when we work outside of agencies, we get tremendous amount of administrative support. So whether it is for credentialing, benefit verification and authorization, getting referrals, scheduling, paperwork that we need to get from the physician's office, forms that need to be filled out, those are usually taken care of for us. And referrals are something that is handled either by the marketing department or somebody else outside that will take care and ensure that referrals keep coming in. OTs do communicate with the physicians on an as-needed basis for the patient care aspect. When work in the medical community as occupational therapists, our clinical judgment is respected. And I'll talk a little bit.
So now I'd like to talk a little bit about the experiences of an OT in an organization that is serving the visually impaired. So as Nalima mentioned, there are a number of supports that are typically in place in other settings. So it is important that there is organizational infrastructure and knowledge around a variety of different topics so that an occupational therapist can be appropriately supported in that organization. So as Nalima alluded to, credentialing is an important part of being able to access insurance reimbursement for services. So credentialing can mean setting up a therapist to be credentialed with Medicare or Medicaid, or with a number of other commercial payers. So there can be Medicare managed commercial payers by like United Healthcare, Blue Cross Blue Shield, Humana. Those also can have commercial and Medicaid plans as well. So it's important as an organization to determine what are the primary payers in your area and to develop a strategy around ensuring that you have the appropriate credentialing so that those services will be provided and covered by those insurances. If your occupational therapist is not credentialed with those insurances, they will likely only get access to out-of-network benefits, which result in a much higher out-of-pocket expense to the patients attending your services. Another thing to consider is an electronic medical record system. So electronic medical records can integrate a number of the components of important parts in terms of operating within the medical model. So electronic medical record systems can integrate the scheduling component, the documentation component, and the billing component. Now, it's not required that an organization uses an electronic medical record system, but it is something that's worth exploring and that could potentially even be utilized by other providers within your organization, even if they are not billing insurances. Another piece to be aware of is around insurance verification and authorization for services. So it is not uncommon that insurances require that there is prior authorization for services. Sometimes they can require that prior to the first visit or may have a limited number of visits, and then prior authorization is required to continue services. In addition to that, it's important that there's a system in place to ensure that when you bring in a new patient who will be accessing their medical insurance for services, that you have verified their benefits and coverage. This can get confusing, and it's important that you have a staff member in place who is knowledgeable around this process so that you can ensure that you do get paid then for the services that you provide. So this ties into this billing component. There are options around billing. It can be within an organization, your billing could be handled in-house, or it is possible to get a third party that can manage the billing processes for your organization. But this is something that's really important to consider and to ensure that you do have someone with knowledge around billing or have the ability to contract with someone outside your organization who is knowledgeable about billing. Medical billing can be complex. There can be denials and appeals. There can be modifiers and other things that are needed in order to get paid for services. And as Nalima mentioned, an occupational therapist may not be knowledgeable about all those pieces because in other settings, they're typically getting support in this area. So it's important that there are resources in place in order to support that billing. Next slide, please. I'll turn it back over to Nalima to talk about documentation.
Awesome. Thanks, Jackie. I love talking about documentation because we, when we work in the medical world, we are so attuned to how we document because documentation brings the money in. And also it helps us as we work through the continuum of care because you can see a beautiful progression in client goals as we work with them. Most of us follow the AOTA guidelines for documentation when we're working with clients. Some insurance may also have additional guidelines that we have that we need to follow. And then collaborate with them to create a plan of care. Plan of care is a document which basically will I'm getting notes that it's difficult to understand, and I'm not sure why, but is this better? Are people hearing me okay? Because I don't have anything around. Okay, so plan of cares are important because they document what we're going to work with the patient on, how we're going to achieve our goals, how long it's going to take us, how often we're going to see the patients, and what the mutual goals are that we have established. Once we have seen the patients, depending on the insurance guidelines, we either have to send this document into the insurance for approval, but we always have to send this document to a physician for their signature because they have to approve the plan of care while we're seeing the patients. We have to be very mindful and follow our licensure laws and scope of practice, because it's critical. There is overlap sometimes in what we do with a lot of the other disciplines, but that's true even in the medical world. So I can be working on walking activities with a patient that had a hip fracture, for example, and so is the physical therapist. But how I document what I do so that I stay within my scope of practice is critical as an occupational therapist. Next slide, please.
All right, so I'll take a minute now to talk a little bit about billing. And one of the things that Nalima and I talked about is that we could easily fill this 90 minutes just talking about billing. So please know that this is not by any means a comprehensive exposure to billing. We simply wanted to give individuals an idea of what's involved in billing for occupational therapy services. So when billing occurs, an occupational therapist must use two different sets of codes. They must use both a diagnostic code and a billing code. So the diagnostic code relates to something called ICD-10, which within the medical model is a way in which we determine the primary and in some cases additional secondary diagnoses or tertiary diagnoses that are the reason for why those services are being provided. So those diagnosis codes can be provided by the referring doctor. So whether it be a primary care doctor, ophthalmologist, or optometrist, there can be guidance provided around those diagnostic billing codes, and the occupational therapist can then determine the services that they're providing and the appropriate diagnostic code that relates to their interventions. In addition to that, there are also billing codes that represent the services that an occupational therapist is providing. So again, just a brief glimpse into this, but just so you get a sense of some of the complexity involved. For example, for an evaluation, there are actually 3 different evaluation codes an occupational therapist can use based upon the complexity of the evaluation that is being provided. So again, that's where an occupational therapist would need to use their clinical judgment and strong documentation in order to justify which code they are using for an evaluation. Again, just to give you a sense of some of the pieces are related to billing. For an evaluation, that's considered a procedure-based or a one-time code. So it is not necessarily time-based, although time can factor into the determination of complexity. But other codes, for example, like the codes that are used to address self-care management or ADLs, which is one of the major codes that are used for the services that an occupational therapist would use, particularly those working in a low vision setting, are actually based upon 15 minutes units of service. And there are some, again, billing guidelines around that based upon the payer in terms of making that determination of the number of minutes that would then correlate to different numbers of 15-minute units of service. So again, these are things where it's important that there is knowledge and skill around the appropriate billing practices to ensure that all those guidelines are being followed. So that ties into this idea around billing compliance. Oh, could you go back one slide again? I'm sorry. So with the billing compliance, that is something in which the occupational therapist does have some knowledge and responsibility, but it's important that the organization also has systems in place to support that, because there can be ongoing changes that occur around billing compliance and can be challenging to stay up to date on. Oftentimes those changes are driven by Medicare, and then commercial insurances and other payers follow Medicare guidelines. So there needs to be a system in place to ensure that your organization is staying up to date on billing changes. Just as a quick example, that change to 3 different evaluation billing codes was something that happened maybe about 5 years ago or so. And prior to that, there was just one code that was utilized. So you need to ensure that when those changes occur, that you are aware of them and can have the systems in place in order to respond to those changes. There are a number of trainings that occur, and some of them that can even be offered for free, but you need to designate a person within your organization that is going to be responsible for staying up to date on those changes. And did want to talk a little bit about revenue. So revenue can vary greatly based upon the payer source. So it's important that you get a sense of who are your primary payers, who are you planning to credential with, and then taking a look at the fee schedule so you can get a sense of what you would expect to recoup in terms of your billing for those services. It's important to recognize that you may not collect on everything that is on those fee schedules, because there are cases in which there are co-payments, co-insurance that would need to be collected outside of those reimbursements that you would receive from the insurance company. So you also need to have a system in place for doing patient collections and statements as well. But it's helpful to get a realistic expectation of what you can expect to get approximately per evaluation and per hour of service for an occupational therapist. For Medicare, it would be reasonable to expect anywhere from 100 to maybe a little bit more per hour of service based upon the billing codes that are being utilized and the payer that's in place. Next slide, please.
Right. So y'all have heard quite a bit about OTs addressing daily living skills, and we wanted to bring this again to the forefront because OTs address daily living skills, including technology, with all diagnosis, because it helps us analyze how the client performance, their response to intervention, and record progress with their intervention. Addressing ADLs and documentation of the same is key for reimbursement purposes, like I mentioned before. So when OTs only function as CLVTs and not, utilize their full scope of their skills, we're shortchanging the clients, we're shortchanging the agencies, and we're also shortchanging the occupational therapists by doing that. There is tremendous value in peer interaction. And I know agencies oftentimes have staff that are already doing daily living skills training. And I firmly believe that occupational therapists can collaborate with those staff members so that the client comes out ahead. And talking about agencies, I'm going to now hand it over to Tiara, who's going to talk about her agency.
Hello, good evening. I am Tiara Long. I am an occupational therapist and clinic operations manager at the Center for the Visually Impaired at the Florence Maxwell Low Vision Clinic. I am an occupational therapist with 6 years of experience in general OT and 3 years in low vision, and I also possess the specialty certification in low vision from AOTA, or the American Occupational Therapy Association. Next slide, please. Thank you. So I will begin to talk about complementary services that are available with the low vision services. There are 3 general pathways that an individual can receive in low vision exam. So initially, we receive several of our referrals from outside providers, so optometrists or ophthalmologists and a few general practitioners. So we will receive a referral from those general providers, and those referrals will be processed under that medical provider. We also receive self-referrals or walk-in clients. So a client may hear of low vision services by way of word of mouth or a neighbor or a friend or a previous client. So we will receive those referrals and we can categorize them as such. In addition to the self-walk-in referrals, we also receive several different referrals and applications from state and community referrals. So this can include vocational rehab. We also have several school systems that benefit from a low vision examination by our doctors and the occupational therapist. So we support the needs of the IEP, or the individualized educational plans, from the school's teachers. Teachers are typically TVIs, or teachers of the visually impaired, that specialize with vision-related needs and coupled with educational needs. So we also support the school system for the students in grades K through 12. We also work closely with supplemental individuals, such as workers' comp cases or social workers or other vocational rehab counselors that have clients that need specialized services. They benefit from that foundational working knowledge of establishing their current level of vision and what their visual needs will be following their daily living skills of desire. Next slide, please. Thank you. So just to further explain the potential referral process, after we receive the referral, either by fax or email or the walk-in referral that completes the application in person, we provide this information to a specific department that gathers individual personal demographics, any medical background information of relevancy. They also collect financial information and insurance information. And we also take the time to decide what are your main goals for seeking the low vision examination and the therapist evaluation. After that's collected from that referral team or the client services department, they also will follow up and determine a schedule for the client to come in to receive the low vision examination. They will schedule that low vision examination based on the schedule for the clinic or whatever is convenient for that particular client. We schedule, in this clinic, we schedule the low vision optometrist for the first hour, and then the second hour will be devoted to the occupational therapist. So that occupational therapist will receive the recommendations from the doctor, and the client will be seen in the same day for both services. If the client is referred from a state agency, such as vocational rehab, the counselor may forego the low vision exam and then advance to the rehabilitative services, which I will also mention later on. But we often encourage the low vision examination to have that functional assessment and also the clinical examination to determine what the most up-to-date and current visual acuity and contrast and glare accommodations that are needed. And then we can recommend to the complementary or rehabilitative services for specific training. Next slide, please. Thank you. So to further explain the low vision examination process for our clinic and for some other agencies, we have the low vision trained optometrist that has undergone specialized training, either by additional certifications or further training within that specialty. That low vision optometrist will perform the examination, which is typically about 1 hour. Then they will provide the recommendations to the occupational therapist or the vision rehab teacher that's on site. After the occupational therapist receives the recommendations, we will do the occupational therapy evaluation. As was mentioned before in a previous speaker, our evaluation determines the patient's basic function, what their desires and needs are, what their desires for occupational engagement are, any underlying impairments that may contribute to this dysfunction for occupational engagement. After we do that background and history and an occupational profile, we will then transition to providing services for the intervention and intervention for the training of the recommended strategies from the low vision optometrist. All of the interventions that we address can include any training for any optical aids, non-optical aids. We also assess lighting modifications, any glare reduction strategies, any compensatory strategies that can be addressed, and contrast sensitivity. And we also address any visual field restrictions. So we would do a comprehensive education and training on all of the available interventions and address this model with any specific daily living skills that are desired for that particular client. At the conclusion of the evaluation, we will not only address the different strategies to minimize the challenges with the ADLs, but we will then provide referrals either internally or externally for the complementary services that the client may benefit from. Next slide, please. Thank you. So the occupational therapist can provide an internal referral or an external referral, and that is determined at the end of the occupational therapy visit where that referral will happen. And then we explain to the client what is going to come after the visit. And then we will also do our referrals for that referral source to follow up with that individual client. Next slide, please. So this slide explains the internal referrals. So within the agency, we have several members of the interdisciplinary team that can provide rehabilitative services to any clients that have undergone the low vision examination and the occupational therapy evaluation. And as mentioned before, some clients prefer to just proceed with the complementary services, although the evaluation is highly encouraged prior to taking this route. So one complementary service is orientation and mobility. These services are provided training by an orientation and mobility specialist. This training allows any client to become more comfortable and independent in their natural environment, whether it be the home, whether it be work, or any unfamiliar or familiar area. They also provide recommendations for equipment, additional devices such as white canes or single point canes or quad canes, whatever is determined to meet the client's physical needs as well as their visual needs. Our occupational therapists or VRTs can also provide daily living skills training. This is a specialized training that can assess and determine specific skills that are needed to improve and facilitate independence for all areas of daily living. That includes cooking, organizing in the kitchen, medications, organizing those meds so they're safely administered. That can be managing finances, cleaning in the home, also leisure reading, whether by paper reading or also by audiobooks. Another internal complementary service we recommend is assistive technology. It may be referred as AT. This is an additional specialized training to improve skills for technology to include cell phone and keyboarding and also computers. So some clients may be able to facilitate the cell phone use with the occupational therapy evaluation as well. So by way of increasing print size on the telephone, by changing the contrast, by adding a voiceover or a talkback feature, or also just general accessibility with the cell phone or the computer. If there is a more specialized training that is needed, we will happily refer to the assistive technology instructor. And lastly, the client may be interested in learning Braille. So we have also provided an introductory course to learning Braille and also reading Braille as an additional internal complementary service. Next slide, please. So for outside services that will complement the low vision examination include vocational rehab. So some clients are interested in working or changing their jobs or finding a better fit job given their visual needs. So we will recommend to vocational rehab services to continue their employment wishes and desires. As long as the client wants to work and is able to work, they are the perfect candidate for vocational rehab. We also recommend community and social services. Some clients, for example, may desire a change in living arrangements. They may want to age in place, so they may need recommendations for caregivers, for home health agencies that can support them remaining in the home. And some clients may prefer to move to a different level of care and are seeking recommendations for assisted livings or independent livings or community dwellings. So we will provide recommendations for areas of aging or Department of Aging health agencies to facilitate that selection. We also provide recommendations for audiobooks, for large print reading materials and statewide accessible services. We also recommend services for Hadley School for the Blind, for general educational classes online and webinars, and also trainings that are done virtually. We also recommend computers for the blind. Locally, they offer computers at low cost or no cost that have software functionalities and computer systems embedded within those technology pieces. So that's an awesome resource. That's great benefit. And then lastly, we can also recommend transportation services for specific counties or statewide agencies that can provide paratransit services. So recommendations for paratransit services, the occupational therapist can complete and certify those applications. Typically, they are required to be certified by someone delivering your care, whether it be a nurse, a doctor, a therapist, someone in that rehabilitative arena. So we will certify those applications as needed. Next slide, please. Okay, so I will pass it to Ashley Bergdahl at the New View, Oklahoma.
Thank you, Tiara. Hi, everyone. I'm Ashley Bergdahl. I am the evaluating occupational therapist at one of our locations at New View, Oklahoma. I have 5 years of occupational therapy experience, 4 years as a generalist and 1 year as a low vision therapist. So today I'd like to discuss how our organization collaborates with eye care professionals as well as the surrounding medical communities to identify potential patients and help broaden our referral network. I think Tiara and our previous speakers have done a really good job of giving a good insight of what occupational therapy does, but I'll go ahead and provide additional insight on how we specifically help our patients here at New View. So New View, Oklahoma is a nonprofit organization. It services patients in all 77 counties within Oklahoma. We have 2 locations within the state, but we do offer remote clinics across the state with, it's about 1 day a month for what we consider to be our outlier patients. So we offer comprehensive low vision rehab services, employment opportunities, and community programs. We also have grant writers that are great at what they do, which allows us to provide free services, as well as providing low vision devices free of charge for people who meet those grant requirements. So our rehab services, they also include a vision assessment by our low vision ophthalmologist, an evaluation and treatment by the occupational therapist and/or occupational therapist assistant when it comes to treatment. And additional referrals within our rehab may include an orientation and mobility evaluation, as well as a consultation or additional training with the assistive technology specialist. You can go to the next slide, please. So I think Tiara's model at her organization is actually very similar to New View's. So I won't touch on as much as she did, because we do offer a lot of those same things, but I think she gave a really good definition and description of what those different services look like. So I'll just kind of go through so it's not redundant on my part. So to touch specifically on occupational therapy here at New View, Oklahoma, I'll go over what our services look like. So occupational therapy, again, is a rehabilitation service that's offered to our patients who may need additional assistance outside of the new eyeglass prescription. So OTs work with those individuals who experience a variety of eye conditions. I would say our primary diagnoses that we see are typically macular degeneration and glaucoma, but those definitely are not the only ones, and we do see a variety. The primary goal of occupational therapy is always to improve their quality of life through increasing their overall independence in everyday activities. So through our rehab services, OTs evaluate each individual and examine ways that we can help prevent accidents and injury, which can be addressed through in-home lighting assessments, environmental modifications. We teach compensatory strategies as well, such as eccentric viewing, visual tracking, or visual scanning techniques. We also enable the patient to participate more fully in recreational and leisure activities through training in different devices or adaptive equipment. So once that patient has been evaluated by the OT, we form that plan of care, and that plan of care is based off of that patient's primary goals. So the patient is then seen by the occupational therapist or the assistant, And then that plan of care is carried out to work one-on-one to address those specific goals. So again, we offer similar to Tierra's organization. We do in-home modifications, which can include placing bump dots on appliances. We work a lot with contrast, so we can apply high contrast tape to stairs or steps, so the patients who have low vision are able to see those barriers more easily. We also teach us high contrast strategies for everyday activities. We perform in-home in-home task lighting assessments. So we assess the best light source through different bulbs and lamps, and we discuss the best placement of that light source. We also do glare reduction. We improve visibility through training in different handheld magnifiers, electronic readers, gooseneck magnifiers. We demonstrate different low vision telephones, talking watches. There's even TV glasses out there to help individuals who enjoy watching TV, but it's difficult for them to see. We also do technology modification where we can modify those cell phones, computers, and train on those low vision phone apps. Some of our higher tech devices, we do typically refer to our assistive technology specialists to have a little more in-depth training on those devices. We work with our patients in the kitchen, so if they're wanting to prepare meals or snacks, we have adaptive devices for that, as well as teaching different compensatory strategies to increase that independence and safety. We do medication management, so a lot of times when we have individuals with low vision, they aren't able to read those devices. So we demonstrate those different audio devices such as audio blood pressure cuffs or audio glucometers, so things like that. And we work a lot with contrast, so working on those high contrast strategies as well. So we can go to that next slide. Go ahead and talk a little bit about how our referrals to our eye care professionals work. So at my location, we actually had a former OD that was a well-known and respected OD in our medical community. And she did a really good job of building those relationships with other providers, which ultimately paved the way for a steady referral base at our clinic. For our new providers, we always like to convey to them that we are not here to take their business. We're here to complement and assist with patients who no longer can gain benefits from those stronger eyeglass prescriptions and or surgery interventions. This is probably one of the most important conversations to have, and we lead with, because it is and has been a genuine concern for providers that may not fully understand what we do and what services we provide. So our doctors here at NewView are very supportive, and in addition, they try to bring awareness to outside providers, and they try to be specific about the needs of the patient and how occupational therapy ultimately increases that patient's success and overall quality of life. That I believe that internal relationship for us has been key to having that continuous flow of patients coming in for OT services at this clinic individually. We can go to that next slide, please. All right, so to assist with our community outreach, so the outreach beyond those eye care professionals, we actually have an employee at each clinic, and they individually go out to different businesses on a regular basis that would benefit from our services and provide information on what it is we do. Those businesses include, but aren't limited to, senior living facilities, doctor offices, state agencies, the Department of Veteran Affairs, even colleges. So these are especially great opportunities to address any doctor's concerns and identify potential new patients, as well as identify those patients who may qualify for our grants. We conduct lunch and learns, we put up booths at local events, and we're members of multiple networks that have a variety of healthcare professionals involved on those boards. So also, in addition to NewView, we also have an internal marketing team. So that ensures that we have an active presence on social media, as well as a general marketing materials to provide to the community when performing those outreach activities. So again, this is specific to Newview, and we're in the presence of multiple occupational therapists who work at different organizations, and they may have different different outreach approaches to both community and eye care providers. So I will go ahead and hand this off to Janice and Jackie.
Hi, I am Janice Heck, and I'm going to, for the sake of time, I'm going to run through this fairly quickly. So let me know if I go too fast, but I am an occupational therapist. I'm the Vice President of Vision Rehab Services at Lighthouse, Louisiana, and I am also an adjunct professor for the University of Alabama at Birmingham. I am blind, and I'm one of the few blind or visually impaired occupational therapists in the country. I've worked in multiple settings for over 25 years. But for the past 19 years, I've been focused on vision rehabilitation. So today I'm here to talk to you about the challenges for integrating OT in the medical model into your existing programs, which tend to be more education-based. So there are some things that you're going to have to consider when you're blending these two models. The first being this, there could be a little overlap with the scope of practice. What I love about OT is the holistic nature and the diversity of it. And you've heard from Beth and Nalima about everything that OTs do and how ADLs are our wheelhouse. And so that's wonderful, but that may overlap a bit with your VRTs or your CLVTs. But it's important to remember that just because OTs do a lot, that doesn't mean that we should do everything. Every profession in the field of vision rehabilitation has a unique purpose and brings value to client care. So the key to success is to make sure that everyone understands their role in your programs and that everyone understands their value for their unique piece of the puzzle for each client's success. So of course, when you have a little overlap, you are most probably going to also have professional tension to deal with as another challenge. But this is where your leadership comes into play, because messaging is everything. A strong team complements each other. It doesn't compete against each other. So it's your job to make sure that everyone clearly understands their roles so that they're not put in a position where they feel like they have to compete. So here's a practical perspective that can help you and your team understand where OT can fit in. There are 617 vision rehab therapists in the United States. There are 462 CLVTs, many of which are occupational therapists. There are 119 CADIS out there. But when I searched up how many occupational therapists are practicing in the United States, there's over 126,000. We all know that there is a shortage of professionals in the field of vision rehabilitation right now. Less than 3% of older people who need our help are not receiving services. So OTs are an ideal solution to meet the needs of the growing number of people who need help. And developing an OT program can help you to fill some of the gaps that you might be experiencing in your services because you can't fill those positions. Another challenge is the varied billing practices. There's a lot to learn, as you can tell from Jackie's presentation. There's a lot to learn when it comes to working with insurance and billing insurance. It's important for you to know that every agency does it their own way. We're all very unique. And so the challenge is for you to figure out what is going to work best for your agency. And the best way to do that is to learn from sister agencies. And so VisionServe Alliance is happy to connect you with other sister agencies that are similar to yours that can help you figure out where to get started with that particular challenge. The fourth challenge is the expense of bringing OT staff onto your team. It is a higher investment, But that's because you're bringing medical professionals with a different type of service that you're adding to your team. But you got to keep in mind, this is going to bring in new revenue streams, and that we can bill insurance where other vision rehab professions cannot. If also expanding your programs to include OT will enhance the physician's perceptions of your programs, because they already understand what OTs bring to the rehab process. So it can help you to build recognition and get more referrals. So the fifth one is hiring and retaining OTs. That can be a big challenge. So vision rehab is fairly new as a specialty in OT, but as the field develops and more opportunities for formal learning are developed, it's going to be easier. At my location, I am a hiring manager, and I've already noticed it is becoming a lot easier to find OTs who are specializing now. But the key to retaining the OTs once you have them is to ensure that your managers truly understand the role of OT and how to integrate them instead of making them conform into your current programs. It is different. The medical model is different. And so you can't expect to just bring an OT into your current model and then just have them plug and play. You know, there's a lot of consideration that needs to happen there to make your OT feel valuable and to allow that OT to help grow a program that's going to be effective for your team and for your services. So now I'm going to pass it over to Jackie, who can talk about what we've learned.
All right, thank you so much, Janice. So just want to highlight a few lessons learned and maybe some ideas and tidbits that can help as you consider what it may look like, excuse me, to add occupational therapists to your team. So as Janice mentioned, there is no perfect formula for success. Organizations are significantly different in terms of the way that they're structured, the clients that they serve, the culture within the organization. So there is no one right way to do this. I think, as Janice mentioned, it's really just important that it's done in a thoughtful way. So there is important to start from the very beginning in terms of kind of establishing how occupational therapists can be part of the multidisciplinary services that are provided. And that can really start from the intake process. So as you begin to have clients come into your organization, really identifying, as you've delineated, what is each provider's scope of practice and where you want them to specialize, ensuring that you then are matching new client referrals to those providers who are the best fit to offer those services. And so I think, and again, this is not always black and white, and this can be a very gray sort of determination and something that can evolve as your team learns to work together. I can give you an example. We had a team meeting just a couple of days ago about a new referral for a client where we weren't really sure whether they should go through our low vision program, our more medical model of working with the OD and OT, or whether they should just go to our assistive technology specialist and really focus on a technology demo with a certain piece of technology that they were interested in. So it was a collaborative team decision. And ultimately, we determined that we wanted them to go to our CADIS. And then at that point could maybe determine if we should direct them then through our low vision program. So it's one of those things that there is no absolute answer to this, but it's something that can be actually a way to build the collaboration and those cross referrals within your team to really talk about how all those unique skill sets fit together. So this ties into that next point of really making sure that you have a system in place for cross referrals. And again, this is involved in making sure that all of your providers have a strong understanding of what each other does and where those strengths lie. A nice way to do this is actually to have team members do observations with one another. We routinely do observations where a team member will then observe and provide some feedback to another team member. And that can be a great way for them to get an understanding of all the nuance of the different ways that they can provide services and the interventions that are available. So that can be a great way to build that trust and to create those systems in place in order to allow for those easy cross referrals amongst the many different services that can be provided within an organization. In addition to that, I think it's really important that you make sure of the way that you're messaging around the integration of both a medical model and an educational model within your organization. And as Janice touched on, this is something that really can start at the top. So as you look at executive level leadership and middle managers, it's really important that they are, through both their verbal and nonverbal messaging, acknowledging the unique skill sets of all team members and really trying to set the playing field equally across those different providers so that those issues of maybe some confusion around or some concern around those scope of practice issues and where there may be overlap, those can be really handled in a proactive way. Your support staff can be a really important part of this as well. Ensure that your support staff can help to facilitate this integration as they work and ensure that they understand all the different areas within your services so that they can be part of, again, matching those clients with the most appropriate services and allowing for cross referrals where they may make sense as well. I think a nice way to help to build that multidisciplinary team across both your medical providers and your educational providers is to make sure that you hold weekly or biweekly team meetings in which you bring all of those team members together. And one of the things that we do at our organization is that we regularly do case studies where we talk about clients. And it's a great opportunity for providers who may even be outside of the scope of what that individual is looking for, or they can provide some input or ideas and assist in problem solving. It also can help to identify where there might be other service providers that could play a role in terms of helping to support that client. So that can be a really nice way to build that culture of mutual respect and camaraderie amongst your team members. And then finally, I think it's important that you can really monitor the undercurrents of what's going on within your organization. And I recommend that you look to do monthly check-ins with each staff member. So we have it set up where we do an individual one-on-one check-in with each staff member. And that's a place where you can talk about specific projects or things that that individual is working on, check in on goals that have been established, maybe through your performance appraisal process, but where you can also identify if there are challenges or issues. And so that you can be tuned into them and really create a platform in which that team member can openly and honestly share with you about how things are working. And so that you can then be sure to address those issues as soon as possible and help to really establish that integrated approach between occupational therapists providing medically based services and other vision rehabilitation providers who might be providing educationally based services. All right, next slide.
Okay, are we on me? Okay, sorry. Okay, guys, let's wrap it up real quick by touching on blindness. You keep hearing the term low vision, low vision, low vision OT. That's because there has been a lot of formal education opportunities available for treating, assessing and treating people with low vision. But what about blindness? Where does that leave the non-visual strategies? So I'm here to tell you that as you heard from Beth and Nalima, OTs are perfectly capable of working with people who are blind and have no usable vision. But OTs do need experience and training to develop their skills in this area, just like any other specialty, because this is a specialty. So the good news here, and the happy ending to all of this, is that there are more formal learning opportunities being developed. ACVREP has been wonderful in supporting OTs through the low vision certification, low vision therapy certification process. But the UAB in Birmingham has also stepped up recently, and they hired me to work with them to develop an elective for their LVOT program on blindness rehab. So I'm very excited that we are starting that now, and there will be more formal learning opportunities to come. ACVREP and the UAB are working closely together to develop more certification opportunities for OTs to be able to assess and treat across the spectrum of vision loss from low vision to no vision. So it's a great, exciting step for our profession, and it's exciting for the whole field of vision rehabilitation. So we'll have many more professionals out there treating the people who need our help. So we want to thank you for coming tonight. We hope we answered all of your questions. I'm sure you have a few more after this presentation. And so I'm going to pass it over to Anicio to go ahead and bring it home.
Thank you, Janice, and thank you to all of the panelists. I know we're running out a little bit over time, but I didn't want to stop anyone because this information is so important. As I mentioned earlier, this is just the beginning of the discussion. We don't expect you to have gotten the skills to go ahead and start your own low vision or OT or medical vision rehab services. But hopefully you have a better understanding of what's possible, what some of the concerns may be before you decide to do it, and perhaps more importantly, who you can reach to in order to get some ideas, some advice. We wanted to give an opportunity for questions and answers, but I don't think we have time. But I did see that most of the questions I think were answered by the panelists, by Beth and Jackie and others. So I want to thank all of you for being with us. As I said earlier, the recording and the slides will be available on the Aging and Vision Loss National Coalition webpage. And if you have any problem in reaching that page or finding the information, please don't hesitate to contact us. I believe my contact and others should be on the screen. And with that, I thank you for your attention, and hope to see you soon in some other venue. Thank you.
Thank you all very much. Great job. Adios.
Thanks, Lee.